Let me start it. So we'll continue with the series of the Thoracic Gurus, and today it's my honor and privilege to introduce to you Dr. Kamran Ali, who is a consultant thoracic surgeon at Fortis Group of Hospitals in Delhi. I'm particularly proud of Kamran because he started his training with me, and he's gone through the whole system, and he's also done an international fellowship in Korea, and he's now in Fortis doing some phenomenal stuff, doing lots of robotic VATs and everything. So he's overtaken his guru. So I'm really, really thrilled to have him with us in the group, and he's going to be talking on current trends in management of pneumothorax. The one thing I want everybody to understand is to please switch off your microphones because we are recording this live. So I don't want any other disturbances. Questions will be taken at the end of Kamran's presentation. As we did last time, I'm very happy to moderate it. So at the end, I will start off with the questions, and then I'll allow each one of you to come in and take questions. I also have some MCQs on slide format. So if we have time at the end of it, we'll discuss some MCQs. So Kamran, the floor is all yours.
Thank you, Professor Khan. Thank you for the warm introduction. And it's indeed a pleasure and honor for me to be here and, talking about something that's going to help the people appearing for the exams. So without wasting much time, I would like to start. So the topic that we'll be discussing today is current trends in management of pneumothorax. And I'll try to take you through the important guidelines and the latest in this field. So let's begin. So what is a pneumothorax? Well, I don't have to really introduce what a pneumothorax is to you, all of you, but it's described as air between the visceral and the parietal pleura. So basically air between the lung and the chest wall, called a pneumothorax. It's important to understand the classification of pneumothorax. And what is most important is that we should know what is a spontaneous pneumothorax. So by definition, a spontaneous pneumothorax is a pneumothorax which develops in the absence of any identified extrinsic cause. So what's important here is that there's no extrinsic cause and there is a development of a pneumothorax. And this form of spontaneous pneumothorax is divided into two major groups. The first is called a primary spontaneous pneumothorax, and the second is a secondary spontaneous pneumothorax. A primary spontaneous pneumothorax develops in the absence of clinically apparent underlying lung disease. So the underlying lungs are apparently healthy, and in spite of that, a patient spontaneously develops air in his pleural cavity. A secondary pneumothorax, on the other hand, is one where there is pre-existing lung disease. And that lung disease can be anything from chronic obstructive pulmonary diseases to cystic fibrosis, to malignancy, whether primary or metastatic, and sometimes in certain cases of necrotizing pneumonia. By definition, there is no apparent precipitating event in either of these pneumothorax. The other forms of pneumothorax that we come across are a traumatic pneumothorax, where there is evidence of a blunt or penetrating injury, which causes air to collect in the pleural cavity. The next form is called iatrogenic pneumothorax, which is secondary to a procedure that we perform, like a central venous insertion or a bronchogenic transbronchial biopsy during a bronch. So that's iatrogenic pneumothorax. And the last is the tension pneumothorax, which is a special category, which I will discuss at the end of the presentation. So it's a fairly common problem encountered across the globe, with few incidents that I have cited here from Europe. And in general, it's seen that it's more common in males as compared to females. What is important is that primary spontaneous pneumothorax typically occurs at rest in about 80% of the population, and there's no precipitating activity ongoing at that time. The other important thing to note and remember is that the recurrence of a primary spontaneous pneumothorax is to the tune of 17 to 54% in the first year. And this disease follows a bimodal age distribution, which is important. When we talk about the etiology of a primary spontaneous pneumothorax, it's been seen that a lot of blebs and bullae can be visualized in the ipsilateral or bilateral lung when you evaluate patients of primary spontaneous pneumothorax, whether during a surgery, whether it's VATS or open surgery, whether during a medical thoracoscopy, or even during evaluation by a chest tomography scan. These changes, which are visible on the visceral pleura, have been now called the emphysema-like changes, or the ELCs. And there was a hypothesis by van der Schuren which said that the development of blebs and bullae is a sequential progression, and eventually it leads to rupture and air leaks out into the pleural cavity. But this hypothesis has not been very widely accepted, and it's still unclear whether ELCs are the only reason for causing pneumothorax. A lot of centers examined resected specimens of lungs in cases of primary spontaneous pneumothorax. What they found on those biopsies was that there was no macro and microscopic sites of air leakage. Rather than that, there were diffuse areas of disrupted mesothelial cells in the visceral pleura. Another interesting thing that they found is there was an overlying layer of inflammatory cells with increased elastofibrosis process. The other very, very important finding in those biopsy studies was when they did autofluorescence studies using white light, they found that there were a number of pores of about 10 to 20 millimeters in diameter. And basically, there was a diffuse pleural porosity. And this has been implicated in the etiology of pneumothorax. And a lot of work is going on to find out whether this is an important reason or not. Now we move to the risk factors which cause pneumothorax. There are a number of risk factors which we should keep in mind, and it's probably an important short note which might be asked in the exam. One of the most important factors, risk factors, is tobacco smoking. Tobacco smoking is associated with about 12% risk as compared to 0.1% risk in non-smokers. So there's 12 times more risk of developing a pneumothorax in smokers rather than non-smokers. Cannabis and marijuana these days have also been strongly associated with development of pneumothorax. Sudden changes in atmospheric pressure and also levels of pollution have been implicated in the etiology of this disease. Height is an important factor, and a number of studies are going on which are correlating height with development of pneumothorax. The reason being that it's been seen that tall individuals have more chances of developing a spontaneous pneumothorax because the gradient of the negative pleural pressure increases from the base of the lung to the apex. So the alveoli at the lung apex in tall people are subject to a greater distending pressure and hence more prone to develop a bullous disease and more prone to rupture and cause a pneumothorax. A low BMI and a catamenial variant, which is seen during the menstrual cycle, are another risk factors for pneumothorax.
Kamran, can I interrupt to highlight a few points?
Yeah, sure, absolutely.
Just go back to the previous slide. This is for all the students. Cannabis smoking particularly causes pneumomediastinum. Typically, so if you get a young patient, suddenly presents with sudden onset of pneumomediastinum or plus or minus pneumothorax, you must ask history for cannabis smoking. This is a classical sort of presentation of cannabis smoking. There's a very important point which he made in terms of changes in atmospheric pressure. Two questions which come to you in the exam when this sort of thing is being discussed. One is, in tall, young adults, why do you get pneumothorax? Which he just explained, that the intrapleural pressure is different at the apex as compared to the base. And that is why the difference in the pressure predisposes you to have a pneumothorax. And the second question that commonly comes is, what happens in an airline flight? And you must know this discussion. And if you want, we can have this discussion at the end of the thing, because two things are important. One is, can these people fly? And number two, when can you clear them for flight after you have treated them? So we'll discuss that at the end. Sorry, Kamran, just carry on.
No, that was a really important point that should have been highlighted.
Next slide.
Right. So I'll move on to the next slide. So what's the usual symptomatology of a patient with pneumothorax? Usually it's an abrupt onset of a pleuritic kind of chest pain, which may or may not be accompanied with shortness of breath. Some patients might even present with some form of shoulder tip pain. What's important is that in primary spontaneous pneumothorax, the symptoms are usually minimal or may not even be present at all, and it may be just an incidental discovery. In contrast to a secondary spontaneous pneumothorax, where breathlessness is a very, very predominant feature. Even if the pneumothorax is small, a person with secondary spontaneous pneumothorax will be more breathless. It's been seen that after presentation of a primary spontaneous pneumothorax, symptoms usually improve. That's probably related to the gradual absorption of air in the pleural cavity. However, sometimes when there are severe signs and symptoms of respiratory distress, you should always think in terms of a tension pneumothorax, which is a prompt clinical diagnosis. When you examine the chest of such a patient, what you will find is that the breath sounds will be reduced or absent depending on the magnitude of the pneumothorax. When you percuss, on inspection, you will find that the ipsilateral chest expansion is not that great, and it's reduced as compared to the other hemithorax. And on percussion, there will be a hyperresonant note because of the presence of air inside the pleural cavity. In primary pneumothorax, it's unlikely to see a hemodynamic compromise or a significant hypoxia. If you find a hemodynamic compromise in presence of a pneumothorax, the diagnosis should move towards tension pneumothorax rather.
1 second, Kamran.
Yeah.
Go back to the slide. These points are quite important because you will probably get a patient with a pneumothorax in the exam, not somebody who's presented with an acute pneumothorax, but somebody who's got a chest drain with bubbling. And when you're clinically examining the patient and you're talking out loud, you must say that I am looking for reduced or absent breath sounds. I'm looking for reduced ipsilateral chest expansion, and I'm looking for hyperresonance on percussion. These signs, however, at the moment are not present because this patient has already got a chest drain inserted. Hence, the lung is showing evidence of re-expansion. So these 3 points which is made are very important for clinicals when you're doing a long case or a short case. You have to actually physically speak out these words to tell the examiner that you know what are the clinical findings in a case of pneumothorax. But obviously, because the chest drain is inserted, you will not get these clinical findings. Somebody's kid is talking in the background, so just switch off your phone, please. Continue, Kamran, please. And I'm so sorry to disturb you, but it's because this is for postgraduate students. These points I want to make to them.
Absolutely. The whole point of this exercise is that the important points should be emphasized again and again so that they become, really embedded in the mind. So, from the clinical examination and history taking, we move on to investigation. So, the usual first line investigation for diagnosing a pneumothorax is a chest radiograph. So when you do a chest X-ray, the usual view that you ask for is a posterior anterior view, a PA view. Very rarely would you need a lateral view of chest radiograph. It's sometimes when you're missing it on the PA view and you're highly suspicious of a pneumothorax, then you might order a lateral view. The other important point here is that inspiratory films are sufficient enough for diagnosing a pneumothorax on a chest radiograph. And a lot of studies have compared inspiratory and expiratory phases of chest x-rays, and they found that there's no need to order an expiratory film. What is the hallmark of a pneumothorax on a chest x-ray is the displacement of the pleural line, which you can see in this image that I've put up, and the absence of lung markings between the edge of pleura and the chest wall. So we all know this is the pneumothorax X-ray. But why is it a pneumothorax chest X-ray? Because there is displacement of the pleural line and there is absence of lung markings between edge of the pleura and the chest wall. So now we come to the size of the pneumothorax.
Kamran, you can just go back to this X-ray.
Yeah.
It's a beautiful X-ray you've put up. This is almost like a tension pneumothorax, isn't it? Because it's a really significant pneumothorax. And you're going to talk about the distance in a minute. My question is to Vinita and the other three guys. What is wrong with this X-ray? If I give you an X-ray of a tension pneumothorax in the exam and ask you to describe, please switch on your microphone and tell us what is wrong with this X-ray.
Sir, it's a rotated film.
Okay. Anybody else wants to take a go? Amol, you're also exam going. Andre?
Yes, sir.
What is wrong with this X-ray? If I show you an X-ray of a tension pneumothorax in the exam, what is the first statement you would make?
Can I take part?
Who's that? Nikhil? No, Nikhil. Wait.
Yes, sir.
Nikhil,
Sir, this is a clinical diagnosis.
Nikhil, wait. Stay out. The question is for the other 3, 4.
Sir, the left hemidiaphragm is lifted up.
Left hemidiaphragm. Okay. Anything else?
The trachea would have been more deviated towards left.
No, I'm just saying that say this was more deviated and this was a tension pneumothorax. This also looks quite like a tension, because if you look carefully, you see the mediastinum is starting to shift. Can you see this?
Yes, sir.
This is starting to shift. This line is starting to shift. If you wait any longer, this guy is going to arrest. This lung will completely collapse. This mediastinum is starting to shift. So what is wrong with this X-ray? Nikhil, you're not allowed to answer because you work with me and I've taught you well. The answer that you have to give is there should... Okay, Nikhil, you give the answer. Come on.
Yes, this is a clinical diagnosis and it should have been picked up before an X-ray.
Excellent.
To be done.
Absolutely correct. Tension pneumothorax is always a clinical diagnosis, and a chest drain should be put in on clinical suspicion. You understand that?
Yes, sir.
So you should never, ever, ever have a CT scan or a chest X-ray showing tension pneumothorax. It means you missed the boat, and it also means that the patient may have died in the process of getting an X-ray done. You understand? This is a very important point. So anytime in the exam somebody puts up an X-ray of a tension pneumothorax, you immediately say that this is not the right thing. The reason why I call this tension also is because you can't see the diaphragm on the right side. Can you see this? The whole diaphragm is pushed down, the whole mediastinum is pushed away. So this is a very dangerous situation. This guy, if you don't put in a chest drain, he's going to die. Either a chest drain or a needle in the second intercostal space. I don't mind what you do, but you should do something. You should never, ever, ever take an X-ray like this, okay? And as Nikhil said, it's a clinical diagnosis. It is not a radiological diagnosis. Everybody understood?
Yes.
Okay, come on. Kamran, please carry on. I'm
Absolutely.
so sorry, Kamran, to stop, but these are so important points that, for the exam, they must know these things.
No, not at all. I mean, I'm assuming we have to, you have to keep interrupting me in between, and that's how.
Thank you. Thanks. Carry on. Please.
Okay, so size of the pneumothorax. First of all, is it really important to know the size of the pneumothorax? And if yes, how do we determine the size of the pneumothorax? So on a simple chest radiograph, it is a little difficult to assess accurately the size of the pneumothorax. However, with the advent of the PACS system at most hospitals, you can now put a marker and measure the size of a pneumothorax. So there are two ways in which you measure the size of a pneumothorax on a simple chest X-ray. One is which is endorsed by the British Thoracic Society, and this size is measured at the level of hilum, and in this diagram it's denoted by B, which is the distance between the chest wall and the distance between the surface of the lung. But important to note that it should be measured at the level of the hilum. And this distance, if more than 2 centimeters, qualifies to be a large pneumothorax by definition. And if it's less than 2 centimeters, it's called a small pneumothorax. However, if you look at the top of the diagram, there's a thing called A. So this is in accordance with the American Chest Physicians Guidelines, ACCP guidelines, which measure the apex to cupola distance, right? So this distance, by definition, if more than 3 centimeters, is a large pneumothorax, according to ACCP. And if it is less than 3 centimeters, it's a small pneumothorax. I hope I've made my point clear. In BTS guidelines, large pneumothorax is more than 2 centimeters, measured at the hilum. And in ACCP guidelines, a large pneumothorax is greater than 3 centimeters, measured at the apex. However, the measurement of pneumothorax in centimeters is not very accurate. So what's more accurate is when you measure the pneumothorax volume. Pardon me for the poor diagram, but I'll try to make an understand how you can measure the pneumothorax volume if it's asked in the exam. So the first method is the light index, where I've marked 2 diameters, 2 measurements. One is L, which is the lung, the diameter of the collapsed lung, and one is H, which is the diameter of the hemithorax of the corresponding side. So the size of pneumothorax in terms of percentage is calculated by a simple formula, where you take the cube of the length of the lung and the cube of the length of the hemithorax, subtract it from 1 and multiply it by 100. I'll show an example of how to calculate the volume. But this is the formula that you should remember. The second method is the one where you use Collins equation. It's more of a CT volumetric analysis. So again, so 3 distances are important here in Collins equation. One is called A, the other is B, and the other is C. So A is the distance of apex to cupola. B is the distance of the midpoint of upper half of thorax. So the midpoint between the margin of the lung and the chest wall in the upper half of thorax is B. And C is the midpoint of the lung margin to chest wall in the lower half of thorax. So there are 3 measurements that you have to take. And the formula is written below, 4.2 plus brackets 4.7 into the sum of all these three diameters. It's a little complicated, but just for the sake of exams, I have put it in. Practically, I've never used this formula, but I don't know if you might be asked this in exam. So if we use the Light's index to calculate the size of the pneumothorax, so I've put an example of that. So if the pneumothorax is of 1 centimeter at the level of hilum on a chest radiograph, it's roughly going to occupy about 27% of the hemithorax volume. And we've calculated this by considering the lungs length to be around 9 centimeter after it has collapsed, and the hemithorax is 10 centimeter. So if you put these numbers into this into the Light's index, you come to this figure, which is 0.27 or 27%. Similarly, if the pneumothorax is 2 centimeter, which by definition of British Thoracic Society is a small pneumothorax, it's still going to occupy about 49% of the hemithorax volume. So you see, you may think that 2 centimeters is a small pneumothorax, but still it's still occupying about 50, almost half of the volume of the hemithorax. So this is important. So of course, CT is definitely a better way to calculate the size of the pneumothorax or measure the volume. Definitely more sensitive than chest radiographs, but routinely in an emergency situation, it's not required in most of the cases. But it would be required, and it would be useful in complicated cases where you have to differentiate a pneumothorax from a suspected bulla, probably in the setting of a complex cystic lung disease, when you're suspecting a tube misalignment, or when you have a suspicion of an underlying lung disease and you think it's a secondary pneumothorax, secondary spontaneous pneumothorax, and patients who've been planning for a surgery. So these are just few examples of how a bulla looks vis-a-vis a simple pneumothorax on a CT scan at the same level. So here you can see some bulla at the mediastinal, near the mediastinal pleura. So it's important, and I assume that most of you would know how to read CT properly, and I know this is not the right class to discuss that, but it's important that you should know how to differentiate a bulla from a pneumothorax on a CT scan, because that can make a lot of difference. Because putting a chest drain in a bulla is probably a crime as well.
1 second, Kamran.
Yeah.
This differentiation is very important when you are dealing with giant bullas. Okay, so sometimes you get what is called as a giant bulla of the chest, which occupies almost half or 2/3 of the chest, and the chest physician may not understand that this is a giant bulla, and they may put in a chest drain thinking it is a pneumothorax. But the problem is, once you got a drain into a giant bulla, there is no hope in hell that this air leak will stop, because it's leaking directly from the inside of the chest, and the drain is sucking the air out from the inside of the chest. So this patient will be solved only by surgery. So this is quite often, Kamran and I, we have both seen patients where the physicians have called us after 4, 5, 6 days or almost a week, saying the air leak is not stopping from the chest drain. And then when we went back and had a look at the CT, we realized that actually the chest drain is sitting in the bulla, in a giant bulla. And in fact, sometimes people have also put in talc into these leaking chest drains, and then they have had severe reaction of allergic reaction to the talc, because injecting talc into the parenchyma of the lung is never a good idea. It's okay to put it on the pleural surface, but once the drain is lying within the giant bulla, you're actually injecting the talc directly into the. It's very important to understand the difference between a bulla and a pneumothorax, and also very important to understand what is what is a giant bula, and it's quite sort of important. I don't know if you've got a CT which will show us what is a giant bula, but if you've not, I'll try and flag it up another time. Okay, thank you.
Yeah, unfortunately, I don't have an image of a giant bula.
Flag it up another time.
Yeah, sorry. So next modality is an ultrasound of the chest. No doubt, it's a very, very sensitive technique to diagnose pneumothorax, but its utility is mostly in the settings of trauma. In fact, there are a lot of studies, mainly from UK, which have shown that it's got a sensitivity of 98% and a positive predictive value of 100% to diagnose pneumothorax in settings of trauma. It's also well established, the role is well established in the diagnosis of pneumothorax in ICU settings. However, its use in the setting of a primary spontaneous pneumothorax has not yet been well established. So you should understand, ultrasound has a role in trauma and ICU settings, but for a spontaneous pneumothorax, it's still not well established.
Let me just interrupt here at the moment, Kamran. In the UK, if you are going to put in a chest drain, I said this before as well, if you're going to put in a chest drain, you are not allowed to put in a chest drain without ultrasound guidance. So though what he said is the routine use of ultrasound in primary spontaneous pneumothorax has not yet been well established. However, this has changed now. And with the NICE guidelines and with the patient safety guidelines, we are more and more using ultrasounds in thoracic surgery and in respiratory medicine. And you cannot put in a chest drain until and unless there has been an ultrasound. And if you look at the evidence shows that ultrasound is better than a CT in identifying loculations. So really, if you want to identify if it's a multiloculated septated problem, then ultrasound has more role than a CT. But in a routine, just one-off pneumothorax, I wouldn't ultrasound the chest. However, if I was thinking of putting in a chest drain, I would recommend it should be done at the time of putting in the chest drain, which means on the left hand, you must have an ultrasound and the needle must be in your right hand. So if you're going to aspirate or you're going to put in a Seldinger chest drain, you must use ultrasound. That is the UK guidelines, and that is medical legally acceptable now. Thank you, Kamran.
Right. Thanks for highlighting that point, Professor Khan. So now we come to the important part, management. Whether it's any kind of pneumothorax, the principles of treatment of a pneumothorax would more or less remain the same, which are elimination of air, reducing the air leak, healing the pleural fistula, promoting re-expansion of the lung, and preventing future recurrences. So most of the guidelines that we would read would be based around these points, and it's very important that future recurrences have to be prevented as well, and that should always be kept in mind. So we'll begin with the management of a primary spontaneous pneumothorax first. So if we look at the BTS guidelines of 2010, they clearly say that patients with a primary or a secondary spontaneous pneumothorax with significant breathlessness and a pneumothorax of any size should undergo an active intervention. So whether the pneumothorax size is small or large, if the patient is symptomatic, he is significantly breathless, he should undergo an active intervention. And the level of evidence is A, which means that a large number of high quality meta-analysis and systematic reviews of RCTs support this statement. It's not a random statement. So important that symptomatic patient, irrespective of size of pneumothorax, should have an active intervention. Right. The next point is that chest drains are usually required for patients who have tension or bilateral pneumothorax, and they should be admitted to hospital. I'll come to this point later on. For a small pneumothorax without significant breathlessness, you can observe, and a good level of evidence suggests that. And you can also select a few asymptomatic patients who have a large pneumothorax and can manage them by observation alone. So again, we see in these 2 points that the decision making has been based on the amount of breathlessness and the amount of symptoms again, right? And the last point here is that patients with a small primary spontaneous pneumothorax without breathlessness can be considered for discharge and can be followed in an outpatient basis, but an early review. He should not be lost to follow up, and you should give particular instructions to him that he has to follow up in the outpatient as early as possible, and in the event of any worsening of his symptoms. And this advice should be clearly written and documented and handed over to the patient.
Kamran, just 1 second.
Yeah.
As he is making these statements, I send you the message earlier that every time you talk in the exam, any statement that you make, you have to say the level of evidence. So as he is making this statement, I want you to, in your mind, repeat the level of evidence. A is a meta-analysis of RCTs. B is a good single RCT. C is case series. And D is expert opinion. So every time he's put a line out there, I want you to interpret that D in your mind and say expert opinion. A, meta-analysis of RCT. B is a good single RCT. Okay, it's very important. So when you talk in the exam, you have to say, if somebody asks you, here is a patient who is presented with a small pneumothorax without any breathlessness, what will you do? You should say, the answer should be, according to BTS guidelines, there is level of evidence B to suggest that observation is the treatment of choice. Did you understand this sentence? That is how you have to answer in the exam. It is very, very important. So you have to say this, or you have to say, in selected asymptomatic patients with large PSP, according to BTS guidelines, there is level of evidence A, which is a meta-analysis of RCTs suggesting that these patients may be managed by observation alone. You have to keep talking this again and again and again. It will not come spontaneously until and unless you stand in front of the mirror and repeat this. And that A, B, C, D has to highlight in your mind. You have to pick this up very quickly and start talking like that. That is the only way, particularly in FRCS exam, it is mandatory that you tell the level of evidence, okay? Either you do 1, 2, 3, 4 or A, B, C, D. A, B, C, D is the guidelines. 1, 2, 3, 4 is the level of evidence, okay? So it's very important to do this. Sorry, Kamran, it's quite important that these guys...
Absolutely. So it's absolutely vital. Yeah. It's absolutely vital to understand these recommendation levels and levels of evidence. Even if you go to a good international meeting, people would be talking about these level of evidence and recommendations, and if you don't know them, you're at a loss. So it's a very important point, definitely. So why suddenly? I mean, is there a role of conservative management? Yes, of course. BTS has proved that there is a role of conservative management. There may be certain guidelines which might differ with the British Thoracic Society in terms of whether conservative management is the way forward. But the trend in recent years, if you read, go through a lot of papers, the trend is definitely towards conservative management in primary spontaneous pneumothorax when patient is not symptomatic. But
sorry, I'm so sorry. One important point here is it's not just simple conservative management, but it is a repeat X-ray done 4 to 6 hours later. It is important. You cannot just see the patient in the OPD, in the casualty, do one X-ray, and then send the patient home, saying BTS guidelines said no need of intervention. No. you have to actually repeat the X-ray 4 to 6 hours later. And if that volume of the air leak is same and the patient continues to be asymptomatic, then you do not treat it. If it increases in size, then it has changed. The situation has changed. And then you have to reanalyze the situation. Okay. So it is important that you do not send this patient home from casualty saying this is BTS guideline. You have to wait for 4 to 6 hours before you repeat an X-ray. And of course, if he's increased, you admit the patient. And you may still not put in a chest drain if it is only slightly increased. But you have to admit the patient. So it's important to interpret these guidelines with caution. Okay, don't just jump in and say that BTS guidelines that send the patient home.
Yeah.
Thanks, Kamran.
Right. So, the BTS guidelines say that if so now the question comes whether you do a percutaneous needle aspiration or a thoracic, or you put in a thoracic drain when it's time for intervention. So when it's time for intervention, the BTS says that needle aspiration with a 14 to 16 gauge needle is as effective as a large bore chest drain, and it is associated with a reduced hospitalization and a reduced length of stay. And again, the level of recommendation is A. So the balance has tilted towards needle aspiration from the conventional large bore chest drains. What's important is that once you've done a needle aspiration, it should not be repeated unless and until there were technical difficulties, like a block tube or a kink tube for the matter. But if you have done it, you failed, you should not repeat it. And once needle aspiration has failed, it's recommended, and it's highly recommended, that you put in a small bore chest drain. A small bore chest drain, by definition, is a chest drain smaller than 14 French. And again, the level of recommendation is A. So, needle aspiration, if it fails, do a small bore chest drain insertion. And the expert opinion is that large bore chest drains are not needed for pneumothorax at all. So that's an expert opinion, so you can still debate about that. But the other guidelines are pretty clear that first intervention is a needle aspiration, and if a needle aspiration fails, then you put in a small bore chest drain.
I'm just going to add a small point here, Kamran, that one thing you've got to remember that most of the BTS guidelines, if you go to the authors, they were all pulmonologists. There are very few surgeons. There are surgeons, but very few surgeons. So somebody is snoring in the background. Can you please either wake up, or somebody is snoring, or switch off your microphone?
I think the lecture is pretty boring.
Lecture, I'm really enjoying it. But somebody has fallen asleep and snoring loudly, so do not do that.
Has to be somebody in India. Because
Okay, carry on. Next.
okay. So if you look at, I mean, it's not just the British Thoracic Society which supports this needle aspiration over a thoracic drain. If you look at a lot of RCTs from 1994 onwards, including one after the British Thoracic Guidelines were released, and these are large RCTs, most of them are in favor of a needle aspiration over a thoracic drain as the first intervention.
Yes.
So the evidence is that needle aspiration is effective for initial management of spontaneous pneumothorax. You can discharge patients following an aspiration with due discharge advice of follow-up. And you can also discharge patient with a small bore chest tube attached to a Heimlich valve, and it yields similar results to needle aspiration. And you can safely send a patient home after adequately teaching them about the management of the chest drain. Another important thing to remember here is that the failure with aspiration is pretty high, and it's to the tune of about 25 to 50%. And when it fails, you should be ready for a second procedure. So again, the next question is small bore or large bore chest tubes. Of course, BTS is in favor of small bore chest tubes. And there are other studies as well which favor this recommendation of BTS. There was a study from Denmark which compared tubes of 11 to 13 French to larger drains above 20 French, and in terms of short-term outcomes, and they found that small bore chest tubes perform better. Another study in 2014, and they compared pigtail catheters to large bore catheters, and they were in favor of small bore catheters again. Some more studies with similar findings we found that small bore pigtail catheters were as effective as large bore catheters. So most of the guidelines and most of the evidence is in favor of small bore catheters. This slide that I want to highlight, where I've compared the British Thoracic Society guidelines with the American Chest Physician guidelines. And there's a stark difference in the way both these guidelines approach patients of pneumothorax. As I said earlier, that in British Thoracic Society, what's more important is the symptom of the patient. And they don't really care about the size of the pneumothorax. So if you look at the first column, in BTS guidelines, if the patient is stable and asymptomatic, and it has a small pneumothorax, you don't intervene. If it's a large pneumothorax, you can observe or you can do needle aspiration. And if it fails, you put in a chest drain. However, in unstable or a breathless patient, in British Thoracic Society, there's no role for determining the size of the pneumothorax, and you do needle aspiration, right? And if it fails, you put in a chest drain. However, in the ACCP guidelines, the first category is similar, that a stable and asymptomatic patient with a small pneumothorax, you do not intervene. However, in a stable and asymptomatic patient with a pneumothorax greater than 3 centimeters, you will put in an intercostal chest drain. Not aspiration, not a small bore drain, you put a regular chest drain. And of course, in an unstable or breathless patient, you straight away go and put in an intercostal chest drain. And there's a criteria which is written beneath, which suggests who is an unstable or who is a stable patient. So for the sake of exam, you should know that a stable patient would be one whose respiratory rate is less than 4 breaths per minute, whose heart rate is between 60 to 120 breaths per minute, who has an ambient air saturation of more than 90%, blood pressure is more than 90%, and is able to complete full sentences between breaths. So yeah, that's a stable snore that I can say.
I have seen everything in life, but I've never seen this. Okay.
I think
I
we
have
should.
all the names, so I'm going to ask him.
Right. So I think this table is pretty clear about the way of approaching. But what we should note here is that the ACCP guidelines came out in 2001, and the BTS guidelines are 2010. So probably maybe the next ACCP guidelines may have some other views. We don't know. Okay, this brings us to the next important question: suction or no suction? A matter of debate always. So BTS is pretty clear about their recommendations for suction, and they say that suction should not be routinely employed, although level of recommendation is B. They say we should imply caution in putting suction because it increases the risk of a re-expansion pulmonary edema. Some people may say that the risk of re-expansion pulmonary edema is overestimated, or most of the times it's just a radiological diagnosis and not a clinical diagnosis. And the third recommendation is a high volume, low pressure suction system. are recommended from their end. So whether you want to put a suction or no suction, BTS says, of course, they're not in favor. But there's little data to really reach to a conclusion whether we should use the suction or no, or we should not use suction. However, it's seen, and there was a study which showed that in 70% of patients with chest drainage alone, without suction, in 3 days, lung is going to expand. However, in patients who have a persistent air leak, with or without incomplete re-expansion of the lung, is the usual reason when we go in and use a suction. And this persistent air leak is arbitrarily defined as continuous bubbling even after 48 hours of you putting a chest drain. So people who are in favor of putting a suction, the theory which justifies the rule of suction is that when you put in a suction, air is removed from the pleural cavity at a rate that exceeds the egress of air through the breach in the visceral pleura. So you're removing air faster from the pleural cavity than it is escaping from the visceral pleura, and this in turn brings the two layers of pleura together and promotes healing and helps in resolution of the air leak and helps in resolution of the pneumothorax. If you use suction, the optimal suction should be between pressures of around 10 to 20 centimeters of water, which translates to -1 to -2 kilopascals. There was an interesting study from UK which showed that prolonged use of suction by pulmonologists may even result in a delay in definitive management, which in turn is associated with poorer clinical outcomes. So as we were discussing before, that we keep on seeing patients who have been put on a chest, who have a chest drain in place and who have been connected to suction, and they're being managed for days together, still without any good outcome, and then they do thoracic surgery referral, and it was demonstrated by Waller and his group that those patients have poorer clinical outcomes when they have been referred late after a prolonged use of suction. So suction or no suction, BTS is no suction. Okay. But recently, I mean, you all must have witnessed the increased use of digital suction devices over the last 5 or 6 years, or probably more than that. And it has its role in the role of digital suction device in patients post the lobectomy is very, very well established, and a lot of data about that. But its role in spontaneous pneumothorax to control air leak is also present, and it's shown to reduce the duration of drainage as well as duration and cost of hospitalization if you use digital suction device after spontaneous pneumothorax. Okay, so before we move on to secondary, would we like to discuss something? Is there something that needs to be clarified?
Kamran, I'm just going to make a couple of points for you guys. Suction is a two-edged sword, as Kamran said. On the one hand, it will allow the lung to come up to the chest wall and bring A to B so that there is pleurodesis, which means visceral pleura touching the parietal pleura. But by the same token, it can also keep that leaking area patent. The fistula will remain patent. So a standard practice would be, for people like me who use suction regularly in their practice, a standard practice would be put the drain on suction -2 kilopascals, give it 3 days or 4 days. If within 3 days the air leak has not stopped, or if the lung is not completely expanded, take the drain off suction, and then once he tolerates the drain coming off suction, you attach a flutter valve. There are two types of flutter valves. One is the proper Heimlich valve, which I'm sure Kamran will show you a picture of, or we'll show it to you later. And in the Indian scenario, we also use a urinary bag with a non-return valve. So what a flutter valve does is it reduces the hydrostatic pressure of the column of water. When you connect a tube, chest tube, to a long tube and connect it to a bottle, that column of water that is there in the bottle creates a column of fluid that is there in the bottle creates a hydrostatic pressure. And very often, the lung has to overcome that hydrostatic pressure of the column of water to push the air out. And that sometimes may not be possible, and that's why you get what is called as a surgical emphysema. So instead of using a bottle with water in it, you can use a non-return valve. That means you just attach a Heimlich valve so that every time the patient breathes in, the air goes out through the valve, but when he expires, no air can come back into the valve. So these guys, you attach them to a simple bag or a non-return valve and then send them home. And then you call them in the clinic in a week's time and repeat a chest x-ray. The way to do it is you repeat a chest x-ray. First, you ask them to cough. If there is no impulse on coughing, you do a chest x-ray. Once you're happy with the chest x-ray, you clamp the tube and keep the patient in a clinical area. Whenever you clamp a tube, the patient should not move away from a clinical area because there is a potential for a tension pneumothorax. Okay, so when you clamp the tube, it's very important that the patient must be in a clinical area. You wait for 2 to 4 hours and then repeat the chest x-ray. And if the pneumothorax is the same as it was before, that means if the lung is expanded and not gone down, then it is safe to remove the tube. So this is a question you'll be asked. How do you remove a chest tube in a patient who is continuing to drain air? So the answer is you have to attach him to a Heimlich valve, mobilize him, make sure he's not getting surgical emphysema, send him home, call him back into the outpatient in a week's time, and then you repeat the chest x-ray. Then you can clamp the tube for 2 to 4 hours. The important thing is whenever you clamp the tube, the patient must be in a clinical area because of the risk of a tension pneumothorax, and then you repeat the chest x-ray. So this is the answer in the exam, which you will be asked. Okay. All right. Does it make sense to you guys? Okay, good. Sorry, Kamran.
No, that's very important. A very important practical decision you sometimes have to take because not always you get patients whose air leak stops as you may desire. You sometimes have to send patients home with a bag with the ICD, and that's when this Heimlich valve or the urinary bag with non-returning valve, which Dr. Khan was talking about, which is a cheaper alternative to Heimlich, comes to your rescue. Okay, so secondary spontaneous pneumothorax. The guidelines are pretty clear in secondary spontaneous pneumothorax that you should be admitting all such patients who present to you for at least 24 hours. They should be receiving supplemental oxygen. If I remember correctly, the flow rate is around 10 liters per minute. And most of these patients will require the insertion of a small bore chest drain. Okay. So again, a small bore chest drain is a chest drain with its diameter less than 14 French. Okay. All of these patients will require an early referral to a pulmonologist, and they should be seeing a thoracic surgeon if their air leak does not stop beyond 48 hours. So, by definition of them, it would be called a persistent air leak. And once you have a persistent air leak, persisting beyond 48 hours, you should refer the patient to a thoracic surgeon. Right.
Sorry, Kamran.
However, yeah.
Sorry, Kamran. I'm so sorry to have interrupt again.
No, not at all, sir.
One thing I want all of you to realize, okay? You're reading through all these guidelines. Have you seen the use of the word bronchopleural fistula? Nobody absolutely nobody uses the word bronchopleural fistula. We talk about air leak. Air leak is a different entity from a bronchopleural fistula. The anesthetist and the pulmonologist very often will tell you that this is a non-resolving air leak with a bronchopleural fistula. That is incorrect. A bronchopleural fistula, by definition, is a fistula between the pleural space and a bronchus, which means that there has to be communication with either a main bronchus or a secondary bronchus or a tertiary bronchus. That's a bronchopleural fistula. Here, what we are talking about, rupture of a bulla and rupture of a small surface thing is an air leak. So please, when you discuss these things and when you talk clinically, do not use the word bronchopleural fistula. You have to use the word air leak, not bronchopleural. Bronchopleural fistula is a much more serious problem which will never resolve on its own. You really need to do surgical intervention because you have to go in and suture or staple or do whatever is needed. But a simple air leak resolves with suction and chest drain. So be very careful about the use of the two terms. They are not synonymous. They do not mean the same thing. So very often the pulmonologists use the word bronchopleural fistula, and I get very annoyed when they say that because they do not understand the pathophysiology of what's happening. This is not a bronchopleural fistula. This is just air leak. And the guidelines are using that word. They are all using the word air leak, not bronchopleural fistula. Okay? So in TB, you get bronchopleural fistula. That's a different thing. In empyema, you can get a bronchopleural fistula. That's a different thing. This is air leak. Thanks, Kamran. I'm sorry to interrupt the flow of your talk, but
no.
it will become more interesting.
It's absolutely fine, sir. In fact, very rightly pointed out that we have to so many times correct the pulmonologist and the intensivist that it is not a bronchopleural fistula. Had it been a bronchopleural fistula, we would be taking the patient to theatre. Rather than bronchopleural fistula, if you really want to use a fancy term for air leak, you can call it an alveolo-pleural fistula. That may still sound okay, but not a bronchopleural fistula for sure. Okay, so you send the patient to a thoracic surgeon when there is persistent air leak. But what if the patient with a secondary spontaneous pneumothorax is not fit for surgery? We'll discuss the surgery part later on. So, if the patient is not fit for surgery, what we have to do is something called medical pleurodesis. I'm sure all of you are aware of what is the pleurodesis. So it's a procedure which is very appropriate for inoperable patients to help them stop the air leak and to help their lung stick to the chest wall. At this point, I would briefly like to talk about pleurodesis because this might be a short note in your exam. I'll just give you a brief overview of what a pleurodesis. So pleurodesis is basically the science of making the two surfaces of pleura stick to each other. And there are basically two broad categories of pleurodesis, a chemical pleurodesis and a mechanical pleurodesis. So you use a number of irritating agents or irritants in the chest like talc, bleomycin to cause chemical pleurodesis. When you do a mechanical pleurodesis, you either do pleural abrasions or you do a pleurectomy. If you do a pleurectomy, you have the option of doing an apical pleurectomy or a total pleurectomy. Surgical pleurectomy is a separate topic, which needs a lot of time to discuss. Here I would like to discuss talc because that's the most important and most commonly used pleurodesing agent that we use. But what's important to remember about talc is that it should be sterilized and graded. I'll talk about it in a while. We should remember that talc slurry is inferior to talc poudrage. The ideal dosage for poudrage is 2 to 4 grams. And the installation should, by default, should always be under direct vision. So talc poudrage under direct visualization is very, very important because you have to evenly distribute talc to all parts of the pleural cavity. You cannot just have focus of talc at one point and no talc at the other point. So you can either do this direct visualization by a medical thoracoscopy under local anesthesia or by VATS under GA. And the success rate is 93 to 97% in almost both of these cases. So the next point is graded talc. So what is graded talc? So it has been shown in a number of studies that talc of a particular size is associated with ARDS, acute pneumonitis, and granuloma formation. And it's been significantly correlated to the size or the diameter of the talc particle. So graded talc is talc with particle size of 5 to 70 microns. You should not use a talc with a particle size of less than 5 microns. No, it will cause granulomas. It is going to cause pneumonitis. There were a lot of studies which were raising doubts about the safety and efficacy of talc pudraj, but the evidence has outgrown the doubts, and it's been clearly shown that talc pudraj does not alter lung function, and you can still do VATS after a talc pudraj. It's not contraindicated. However, the VATS after a talc pudraj becomes a little difficult. The recurrence rates after talc pudraj are almost similar to mechanical pleurodesis, provided talc pudraj was done under direct visualization. So that's a little bit about pleurodesis. So,
hang on, Kamran. Just
Sure.
discuss this a bit more. So just a few more points. This is beautiful. What you've just shown us was excellent, Kamran. So my two or three things which I want to add to it is the normal talc that you get, the talcum powder that you get is a very low molecular weight talc. The particle size is less than 5 microns. Hence, you cannot sterilize your normal talcum powder and use it in the chest. I've had this question asked to me by many people who phone me about doing talc pleurodesis. So it's quite important that you cannot use normal talcum powder, okay, QT, Cura or Pond's. You cannot use that. It has to be surgical talc, okay? And the company, as he said, is Terry Talc, which is available in India. And it is available in two forms. One is in a bottle with a powder, or number two, in a bottle which is connected to an aerosol. So in a bottle, you have to recreate the talc. You have to put it into a blowing device to blow it into the chest. Whereas with an aerosol, you can just press it. So the aerosol is like putting your body freshener on you. So you can, it has got a long tube at the end. So you can just put it in there and press the button and push, it will all go into the chest. So that's important to remember. The talc, if you ever do a talc pleurodesis, a medical bedside talc pleurodesis, you have to remember that talc is a severe irritant. And if you blow it on the chest, on the pleura, in an unanesthetized patient, you are going to cause severe pain to the point that you might have an arrest, a cardiac arrest. So whenever you do bedside pleurodesis, you have to make a solution which is 100 ml of saline plus 20 ml of lignocaine. Okay, it's very important to mix and then add 4 grams of talc and make a nice slurry, and then you push it through the tube into the chest. It is important that the patient is moved every 2 to 3 minutes or 5 minutes so that the slurry reaches all corners. So you have to turn the patient, supine, prone, lateral, everything to allow the talc to reach all areas of the chest. Now, many a times I've seen this, people put in a talc and they clamp the tube. That is the most dangerous thing you can do, because you think you're clamping because you don't want the talc to come back into the bottle, to leak out into the bottle. But what you're forgetting is that the patient has got air leak. And the moment you clamp the tube, you are raising an issue of a tension pneumothorax. So you should not clamp the tube. Instead, what you should do is you should use extra long tubing attach it to that. So once you've injected the talc, attach an extra long tubing and hang the tubing with a IV fluid stand, so that instead of the talc has to go up the column of the tube and then down, so it will not escape. Okay, so you have to use extra long tubing to hang it up above the level of the patient so that the talc doesn't escape out. And most importantly, you must give patient at least one shot of antihistaminic, okay, because these guys can get severe reactions. And you must keep an arrest trolley in the vicinity of the procedure that you're about to do. And you must keep a steroid injection ready, okay, hydrocortisone steroid injection ready, because these guys can. I've had 2 cases where we did a bedside pleurodesis and the patient arrested. So when you talk in the exam of the procedure of talc pleurodesis, you have to mention all these factors. That you have to make sure there is lignocaine in the solution. You cannot clamp the drain. It has to be extra long tubing. You have to make sure that you give an antihistaminic or a Piriton before you start the procedure. A dose of steroids should be handy, and arrest trolley. These are all factors which you have to put. So I'm hoping that you're making these notes so that when it comes to the exam, you will be fluent with these procedures. Okay, thanks. And another thing is talc, preferably in my personal clinical practice, I prefer to use mechanical pleurodesis or a pleurectomy. I personally do a pleurectomy for the simple reason that in a young patient, I don't know what the talc is going to do 30 years or 40 years down the road. This comes from the experience of asbestos and mesothelioma. So that is why I personally try to avoid using talc in a young patient. Though there is enough literature to say that talc is safe, but I have a worry of putting a foreign body, which I don't know what's going to happen 40 years down the road. But if you say you're going to do talc pleurodesis, that's all right. I would use a talc pleurodesis in a young patient only when it is a malignant effusion, because I know that this guy doesn't have a long life and it's a purely palliative procedure. So in those situations, I will always use talc in the chest for pleurodesis. But in a simple pneumothorax, I personally prefer to do a pleurectomy rather than a pleurodesis. But I will use talc in secondary spontaneous pneumothoraces because these are usually elderly patients. They are 60, 50, 70. So those guys, I'm not so worried. But in the 18 and 20-year-olds, I have a slight concern with using a foreign material in the chest. So this is the thought process. It doesn't matter what you say in the exam as long as you can justify your thought process. What they want to hear, what the examiner wants to hear is you're thinking logically and you're thinking, in a scientific way. So that is okay. So patient safety is most important. So you have to demonstrate that you are aware of the various techniques, and more importantly, you are aware what are the complications of the various techniques and how you will tackle these complications. That is what you have to be able to tell in the exam. Okay? Thanks, Kamran.
Absolutely. So the next part of the talk is a thoracic surgery referral. So when do you refer a patient for a thoracic surgeon? So we've all been waiting for this. So the indications for a thoracic surgery referral are a second ipsilateral pneumothorax. So you've had pneumothorax on one side, you've treated the pneumothorax, whether by needle aspiration or a small bore or by observation. But if you get a repeat pneumothorax on that side, that's an indication for seeing a thoracic surgeon. Number 2 is the first contralateral pneumothorax. So you had pneumothorax, say, on the left side, and then a few days later, you develop a pneumothorax on the right side. Time you send the patient to a thoracic surgeon. Or you have a patient who presents with a synchronous bilateral spontaneous pneumothorax. No doubt the patient goes and sees a thoracic surgeon. So a patient where you've put in a chest drain for a pneumothorax and the patient has persistent air leak, and you've 5 to 7 days have passed, the air leak is still, the chest drain is still bubbling, or the lung has failed to re-expand, the patient needs a surgical consultation. Or sometimes along with a spontaneous pneumothorax, the patient may also have a spontaneous hemothorax. That's also an indication for seeing the surgeon. The other two categories are special categories where we mentioned the professions at risk, like pilots and deep sea divers. So for these patients, you may actually offer a thoracic surgery referral or a thoracic surgery on the first instance as well. It's about patient choice and his profession, because if he's a pilot or a deep sea diver, he's at risk of developing a second pneumothorax, and he doesn't want to develop that pneumothorax while he's in the flight or while he's deep sea diving. So for such patients, personally also I offer them surgery at the first instance, and I've seen my boss, Professor Khan, also following a similar pattern. I don't know what he does these days, and pregnancy. So that's when you refer the patient to a thoracic surgeon.
Okay, just
So, yeah.
two more points to make in this. The professions at risk with the current new generation of people. There are a lot of people who are traveling a lot these days. The young professionals, particularly the IT guys and the management guys who are doing a lot of air travel. These are the ones in which I will discuss the possibility of a recurrence in an airline scenario. And if they make a choice of having surgery, I will offer them surgery. So this is slightly changed with the new world, because people are flying, and the last thing you want is even if there's a 15% risk of a recurrence, if it happens in a flight, you're in deep shit. So these are the persons I will offer surgery. Now, just another point I want to make, because he has mentioned concept of spontaneous hemothorax. Now, this is something that you have to understand. Why does this happen? Most of the times, you will find that these are young people with an adhesion present at the apex of the lung, okay? And this adhesion has been present congenitally. So these are usually young people with tall chest who have this adhesion at the apex, who've had either pneumonia or present congenitally. But this adhesion becomes neovascularized. So there is, blood vessel running through this adhesion. And when that rupture happens, these are really problematic, because A, that area starts to leak blood, and B, that area does not heal very well because the lung cannot collapse away. There's a partial tear, which means the adhesion keeps that tone area open. And so the lung does not collapse away completely. And so you get this trickling of blood from the top of the chest, which causes the hemothorax. And B, there is consistent bubbling, because if the lung collapses away, that tear falls down and heals over. But here, the adhesion is keeping that tear intact. So these are a special group where if you look carefully on a CT, or if you look carefully on a chest X-ray, you will see that the lung has collapsed away, but the apex it looks as if it is stuck to the apex. And lo and behold, when you do VATS in these people, you go in there, you will always find that adhesion at the apex, which is holding the lung up and causing a spontaneous bleed. Now, you may think that why should it cause hemothorax, so much hemothorax? Well, even if it leaks at 1 mil a minute, 1 mil a minute over 60 minutes is 60 ml an hour. And 60 ml an hour over 24 hours is almost, 6 times 24. So that's a lot of blood. And that is why these are the ones which you must go in and operate. So spontaneous hemothorax is my indication for surgery. I do not wait at all, even if it's a first episode, because it will never stop. Because the lung is pulling down, the adhesion is pulling up, and this air leak will never stop. So that is why I operate on these patients. Okay, thank you.
Right. A very valid point made by Professor Khan here. So now we come to the point of that the patient has reached the thoracic surgeon, and now it's a matter of operating. So there's a lot of debate whether we should do VATS or we should do a thoracotomy. So BTS guidelines is pretty clear about what they want, and I'm not in 100% agreement with what the BTS guidelines recommend for lung procedures. So they say that open thoracotomy and pleurectomy remains the procedure of choice with the lowest recurrence rate, about 1% for difficult or recurrent pneumothorax. And it's a grade A recommendation, level A recommendation. And they say that VATS with pleurectomy and pleural abrasion is although better tolerated, but has a higher recurrence rate, 5%. So they go in favor of open thoracotomy and pleurectomy, and they say open surgery is the gold standard in this.
Let me just interrupt here, because
Sure.
you have to understand that number one, BTS guidelines are 2010. They were looking at data over the last 15-20 years. At that time, the VATS group had not put forward enough publications and enough data. So most of the studies that had been done as a RCT were open thoracotomies, because in those days, early 2000s, everybody was still doing a open thoracotomy, albeit it was not a full-fledged thoracotomy. It was a small mini thoracotomy done in the Petit's triangle. You know, the Petit's triangle at the back of the chest, just below the scapula. So there, when you go in, there is no muscle in that area, because latissimus dorsi goes to one side and your rectus down goes to one side. So you actually just get into that space without cutting any muscles, and then you put your hand in and do a pleurectomy. So this was open thoracotomy. Sounds like a very nasty big incision, but really most of those studies were actually looking at small thoracotomies done in the Petit's triangle in the lumbar area. And the reason why they have recommended this level of evidence A is because those were the only studies which we had. Now, when it comes for time for us to relook at BTS guidelines, I'm pretty certain in the last 10, 12 years, we've got much more studies of VATS. And VATS will probably be superior to open thoracotomy in terms of outcomes. So this data is based on actual published data. So if you say this in the exam, you're not wrong, because this is what the BTS guidelines says. But you must say that there is more studies now coming, which will change probably in future.
Yeah, absolutely. I agree 100%. And he has already explained what I was going to explain in the coming few slides. That if you look at the ERS guidelines of 2015, they've clearly mentioned VATS is the preferred surgical approach over open thoracotomy, and they are backed by evidence. So probably the BTS guidelines, as Professor Khan mentioned, were based on studies which were slightly older, and when thoracotomy was the main approach rather than VATS. Especially this study, which was published in Lancet in 2007, where it was a meta-analysis, and they identified 29 studies, but out of which only 4 were randomized and 25 were non-randomized. And they found that there was a 4-fold increase in recurrence of pneumothorax after VATS. Well, such a meta-analysis is obviously not very convincing, because you're mixing randomized as well as non-randomized studies. Especially the ratio is also skewed, and the studies span over more than 20 years, as mentioned by Dr. Khan, and so it's quite questionable. In fact,
Kamran, just come back to this study. Just come back to this study. I'm sorry, I have to put in my bit in this, because
absolutely, yes.
What also is different in all the previous studies is the procedure that was done by VATS. It's not just that, but what did they do? And this is a real mixed bag of procedures where, people were learning VATS, and so they did pleural abrasion. Some people just did apical pleurectomy. Some people just did talc and things like that. So it's not about approach. You see, with open thoracotomy, everybody did a pleurectomy, and that was a standard approach. Whereas with VATS, because of efficacy and expertise, and most of the times these cases are done by the junior most guy in the unit, by the SHO or the registrar. So the level of expertise has not been mentioned, and the type of surgery that was done by VATS was not analyzed. So even though they did an RCT, they did a meta-analysis of all RCTs, they actually did not look at what procedure was done by VATS. And that is why they came up with this figure of 5% risk of recurrence. So when you read these sort of studies, you have to understand what is the background of these studies. So yes, that open thoracotomy has less than 1%. VATS has about 5% risk of recurrence. But the reason is not just the procedure that was done, but also the level of expertise of the surgeon who was doing this. And most of the times it was the junior guy who was doing this. So that is how you have to interpret this data. Thanks, Kamran.
Absolutely. In fact, subsequent analysis of the same studies, of the same RCTs, when they did not mix the non-randomized with randomized, they showed that these findings were not confirmed. And in fact, it showed that with VATS, there's a reduction in analgesia use, and they have shorter hospital stay as compared to open thoracotomy. In fact, in addition to demonstrating equivalence of VATS success to open thoracotomy, a number of RCTs have also demonstrated physiological benefits of VATS over thoracotomy, including in postoperative spirometry, which is a paper by David Bula, and in gas exchange, which is a paper in EJCTS. And they say that there's definitely physiological benefits of doing a VATS bulectomy, pleurectomy over a thoracotomy as such. In fact, the other reason, which Dr. Khan has already mentioned, that there's a demonstrable learning curve in the use of VATS, and by when they were collecting evidence and they were collecting data, probably this learning curve can be the reason of explaining the higher recurrence rates for technique, which was reported in the earlier series. So if you are doing a lung procedure, what is essential? There are a number of surgical procedures, number of techniques which have been developed over years. But what remains consistent, and which has also been proven by Nonhem et al. In a multivariate analysis, that they said that the only significant predictive factor of a recurrence of a primary spontaneous pneumothorax is that when you fail to excise the lung apex. So what he meant was that sometimes you may not even find a bulla, you may not find blebs, but you may find that when you do an underwater puncture test, there is some area of lung which is leaking or bubbling air underwater, and that area is most of the times the apex of the lung, or in some situations the apical part of the lower lobe. So that has to be resected, and if that is not resected, it's a significant predictive factor of recurrence. The ERS guidelines talk about a lot of techniques which surgeons use for persistent or recurrent primary spontaneous pneumothorax. So as per ERS, routine excision of the apex of lung is controversial. They say if you do a underwater puncture test and you find there's a leak, you resect that. Surgical excision of blebs or bullae, the surgeons have agreement that it is to be done. Controversial as far as the pulmonologists are concerned. Bulectomy is definitely better than a bulla ligation. So bulectomy, when I say bulectomy, I mean bulectomy using a stapler. So it's definitely superior to bulla ligation. There are studies which talk about covering the staple line with an absorbable mesh, or covering the staple line with Surgicel, or some other, hemostat or some. So it's still to be confirmed. There's no conclusive evidence about that. But people in Korea and Japan routinely cover their staple lines with absorbable mesh, and probably in a year or two they're going to come up with their data, which probably in the preliminary evaluation was talking in favor of covering the staple line with absorbable meshes. Use of coagulation and electrocautery for blebs and bullae is controversial. The valves are coming up. I have little experience about valves, but in the ERS guidelines, it's still anecdotal. Atal Kodraj, we've already discussed. It's got a good success rate, but it's not advisable as the only treatment when you have a significant bulla. So you have to do something about the bulla and do fluorodesis in the form of talc or whatever. So that's about the surgical management of primary spontaneous infection. Would you like to add something, Professor Khan?
Yeah, the use of absorbable mesh has been published already recently by the group from Taiwan. And this is something that you must know, that they talk about putting a large mesh as a curtain over the whole lung. So they take in the mesh and they place it on the top of the lung and then fire a stapler at the apex of the bulla. So they do an apical bullectomy, and in the staple line, they include the mesh, and then the mesh is unrolled like a curtain on the surface of the lung, and that mesh acts like a pleurodizing agent. So instead of doing a pleurectomy or an abrasion, they allow the mesh to act like a foreign body to stick it to the chest wall. This got published, I think, a few months ago, and in fact, I was in Taiwan last week or the week before that, and we had a long discussion on this. So remember this, these are newer advances in management of bullectomy, in management of pneumothorax. So use of absorbable meshes to stick it to the chest.
Right. So that brings me to the last topic that I get to today, which is tension pneumothorax.
Can I just talk about endobronchial valve just for a minute?
Yeah, sure, absolutely.
So just to let you know, guys, sometimes nowadays the endobronchial valve is actually licensed for use in stopping prolonged air leak. And the way you do it is you put in a bronchoscope. So you've got this patient who's got a chest tube with a bubbling chest drain. Now, the problem is, where do you put in a valve? These are very expensive valves, and you can't just block everything. So what you do is you put in a bronchoscope, and you put in a flexible bronchoscope onto the side that you are going to do. And then you take what is essentially a Fogarty's catheter. I think I previously spoke about collateral ventilation when I was talking about endobronchial valves. And so it's a similar kind of catheter. So you put it into every segment of the lobe. So you push it, you go into the upper lobe first and then put it into apical, inflate the balloon and see if the air leak is stopping. Deflate it, anterior, posterior. So you go into every segment of the upper, middle and lower systematically, and you will find one segment where the air leak will stop. When you come across that segment, you actually deploy the valve into the thing. So what the valve does is it causes atelectasis of the distal lung. So when there is atelectasis of the distal lung, the lung collapses over itself, and that area which is leaking air gets a chance to heal over. See, the problem with prolonged air leak is that air is continuously going through this tear in the lung, and it's not giving a chance for the cells to join together. So the valve actually causes an atelectasis of the segment and allows healing. And then gradually you'll be able to take the drain out. But the key thing in these patients is that 6 to 8 weeks afterwards, you've got to go back in with a bronchoscope and take the valve out, because that valve has no function there. So otherwise it will migrate and go on to the other side, you see. You've got to go in and you've got to take the valve out so that the lung then re-expands. So this is a healed lung which will re-expand, and so there is no risk of a pneumothorax. That's quite important. And this is actually an FDA approved technology. So the valves have been approved only for two things. One is broncho valve, BVRS, and one is use in air leak. In fact, the first FDA approval came for the valve in the use of prolonged air leak, not in BVRS. BVRS came much later. The first approval was in prolonged air leak. So it is a technique that you can use. But these are expensive valves. Each one of them costs about 1,500 to 1,800 euros. And sometimes you have to use more than one valve. And also the problem is sometimes the patient may cough it out, or the patient may migrate. Coughing it out is okay, but if it migrates to the other side, it will cause atelectasis of the normal side and predispose the patient to lung infection. So this is something that you've got to know and remember. Thanks, Kamran.
Yeah. In fact, I had witnessed one such incidence of valve migration. It was in Japan at Tokyo Medical University. So they used something called the endoscopic Watanabe spigot, EWS. They did it for a patient, a young guy. The air leak stopped. The procedure was a success. But the next day, his other lung collapsed. And they did a bronchoscopy and found that the air leak has again started. The other lung has collapsed because the Watanabe stem migrated to the other side. So that's a dangerous situation.
Yeah, Watanabe spigot is just a ball of plastic. It's like an elongated ball of plastic, which you just place there to, it's like, you know, the drain pipe when in a sink, you've got something to fix it. That's what a Watanabe spigot is. You just push it into that segment and hope that it stays there. The problem is it doesn't have anything to anchor it to the mucosa of the segment. The valves have hooks on the side. When they open up, there are hooks on the side which anchor into the mucosa and prevent migration. The Watanabe spigot is just a flat silicone sort of thing which you plug in, and so it has got a high chance of migrating. Particularly if they cough out loudly, bang, it can go either to the same side, another lobe, or the opposite side.
Right. Okay. So the last topic for discussion today is tension pneumothorax, which we have partly discussed already. That it's a clinical diagnosis and an emergency situation with hemodynamic compromise. The guidelines from the British Thoracic Society about it are that it's a medical emergency and it requires a heightened awareness in a specific range of clinical situations. So all the ER people and everybody who's taking care of the casualty should be aware of this entity. And as pointed out by Sir, that the diagnosis should be made clinically and the patient should not be sent for CT scans or chest x-rays for attention pneumothorax. The treatment is with and with high flow oxygen. And as I said, it's the second intercostal space is the usual site for putting in a needle. Some clinical situations where tension pneumothorax arises it's often seen in patients who are getting positive pressure ventilation in the ICU, patients who've had blunt or penetrating chest trauma, patients who've had CPR, patients who have bad lungs, bad underlying lungs like COPD, or patients who have acute exacerbations of asthma, patients whose chest drains get unfortunately blocked or clamped or get displaced, even patients who are receiving non-invasive ventilation in the form of BiPAP can end up in tension pneumothorax. And another group is patients who are undergoing hyperbaric oxygen treatment. So these special situations, you should always keep in mind that a patient can develop tension pneumothorax, and any change in his clinical parameters, which means if he's having tachypnea, if his breath sounds suddenly are absent, his hemodynamics get altered, you should think of tension pneumothorax. So yeah, that's all from my end. Thank you very much. And if we have time, we can discuss a few more things that's said by Dr. Khan.
Fantastic. Kamran, I think this was the most exhaustive lecture I've ever heard. It was beautifully covered, and I think you've covered almost everything that we had to speak. And really, really well done to you. I think it's fantastic. We need to do this more often with you. A couple of points before I ask the audience to start talking about it. One or two things that is worth mentioning. One thing we have not mentioned in this scenario is the incidence of pneumomediastinum. So we spoke about everything else, but we didn't speak about pneumomediastinum. So pneumomediastinum is obviously air in the mediastinum. It commonly occurs when you have people who have a cocaine addiction or ganja, smokers. These are the guys who usually pneumomediastinum specifically. It can also happen in patients with severe emphysema, who have got, or patients with cystic fibrosis, who will usually have very stuck lungs on the side, and then the mediastinum is relatively sort of not that stuck because it's a mobile with the heart and all that. So that area of the lung might rupture and cause a air leak and cause pneumomediastinum. 99% of the times, and one more etiology which I forgot to mention is the presence of either an esophageal rupture or a tracheal injury, tracheobronchial injury. So these are the clinical scenarios where you get pneumomediastinum. Most of the times, if it is just a spontaneous pneumomediastinum, the management is purely conservative, which means you watch them, you get the appropriate investigations, which includes an X-ray chest, a CT scan, and an echocardiography, because you do want to know what's happening to the heart. You do not try to treat this aggressively. Do not try to put in chest drains, because it's very difficult to know which side is leaking air. And most of the times you'll find that the lung is very stuck. Whichever side you go in, the lung is very stuck. So until and unless the CT scan shows an associated pneumothorax on the side, I will treat most pneumomediastinums conservatively. Unless there is a definite etiology like esophageal rupture, or there is a tracheal or bronchial injury. If both of these are there, then you obviously have to get in there to sort out things. So most of the management is conservative. If it is associated with the pneumothorax, you'll put in a chest drain. If there is an associated etiology, you might actually have to treat the etiology. There is no real role of putting in drains into the mediastinum. You can't really get into the mediastinum. So that is something that you might actually, a CT scan or an X-ray sometimes put up in the exam on one of the Viva tables with the pneumomediastinum, and you've got to know what to say. Okay. So I think we have more or less covered almost everything, Kamran. I think we've been going on for almost an hour and a half now. So I'm going to leave it open now for the audience. If there's any question they want to ask, please feel free. I'm very happy to answer anything. Kamran is very happy to answer. Yes, Andre.
Yes, sir. Just one thing. The talk, the use of talk as Pudraj versus slurry. So we understand that Pudraj has a higher degree of recommendation than slurry.
Yes.
And the Pudraj, despite all that aerosol, propellant and all, it can be used only under GA and by VATS.
Not necessarily.
No, it can be used by under local anesthesia by the pulmonologist when they do medical thoracoscopy.
It can be used under local. It's not a problem.
Right, but not via thoracotomy. Matlab, you can't reach all those places. Pudraj.
By a thoracotomy? Sorry, I didn't understand that question. Did you just say thoracotomy?
Yeah.
Yeah, you can. I mean, with thoracotomy, you can reach anywhere you like. But why would you ever do a thoracotomy in patients who just want to put in a tank? I've just put in a small incision, camera in. The cannula goes parallel to the camera, and under vision, you just spray it all over the place. And it's called as a snowstorm appearance. You have to create what is called as a snowstorm appearance, and 4-gram talc is more than enough. People use 6, 8, God knows what. You see videos on the internet with all sorts of things. 4 grams is usually enough. There are 2 types of devices. One is a handheld pumping device. So you connect it and you pump and that powder goes in. The other is a foot device where you have a button at the foot and that connects to the device. And when you press the button, you get a jet of the spray. It's like a jet insufflation. You can use whatever you like. Jet insufflation is sometimes a little more dramatic, as in you can't control the pressure at which it's going in. So there is no study which has studied A versus B, but whatever you have in your theater, but most of us use a normal pump, the BP cuff thingy.
Right.
Or nowadays, I have started using the spray. That's easy.
Spray.
Go and you spray it all over. It's available now as a spray, aerosol spray.
Okay, got it. And just one more quick thing, that high flow oxygen helps the lung to re-expand, is accepted, but what is the evidence regarding this, and how does it help the lung to expand, high flow oxygen?
Kamran.
So the hypothesis behind that is that when the air in the pneumothorax has a high concentration of nitrogen. So if you give pure high flow oxygen, it helps to displace that nitrogen and helps that nitrogen to reabsorb into the lung and helps to resolve that pneumothorax. The BTS guidelines for secondary spontaneous pneumothorax and the ERS guidelines are in favor of giving high flow oxygen, and they say it's scientifically backed. So yeah, the reason is the nitrogen there in the pneumothorax air.
Oxygen in the air in the pleural space increases the solubility of the air. By displacing nitrogen, it increases the solubility of the air. Thereby, the reabsorption of the air is faster when you give high flow oxygen. That is the philosophy. So you increase the concentration of the oxygen. And oxygen, as you know, is the most soluble at alveolar level across capillaries. It passes very fast, as opposed to that CO2 or nitrogen does not pass as fast. So to increase the oxygen in the air in the pleural space, and that allows quicker reabsorption across the pleural membrane. So, the permeability of the basement membrane of the pleura to oxygen is higher. And that is why you increase the concentration of oxygen. So it goes into the system. That is the philosophy.
Right, got it.
Nikhil raised a hand. Nikhil, did you just raise a hand? Nikhil, are you awake or are you snoring?
No, sir. I'm awake.
I have found out who was snoring. I'm not going to tell you, but I have found out who was snoring. Because I have the control of all the microphones. I switched off that particular microphone. So I knew who was snoring. Okay, next question, please.
Tabulate the difference between, yeah.
Yes, Nikhil.
How to tabulate the difference between air leak and a bronchopleural fistula air leak?
Kamran, you want to take this?
Yeah. So as we were discussing, you can from now onwards we can call air leak as alveolar fistula, and bronchopleural fistula is a bronchopleural fistula. So bronchopleural fistula, by definition, would be a fistula between the main bronchus, the primary bronchus, or the secondary bronchus with the pleura. But if the communication for the pleura is with the alveolar at the alveolar level, just at the surface of the pleura, it's a air leak. Usually for bronchopleural fistula, the magnitude of air leak, if you are measuring it with the digital suction device, or if you are measuring it on a plurivac system of drain, you will find that the bubbles might be reaching up to the 7th column of the plurivac. Or if you're using a digital suction device, the leak may be up to 5,000 ml per minute, or even, the machine may not even able to measure the amount of air leak. However, for a simple air leak, it will not be of that high a magnitude, and it would be easily measurable. With a bronchopleural fistula, you may find that in spite of using negative suction on your chest radiographs, your lung may not have expanded. Whereas in small air leaks, with a good negative suction, and if there's nothing endobronchially, your lung should expand well. And in terms of management, if it's a bronchopleural fistula, you will have to go in surgically to repair the bronchopleural fistula. Either you do a suture ligation, or you do a staple resection, or the choices can be made on the table. But most of the times, a simple air leak can be managed conservatively. That's my
That is
take.
correct. That I completely agree with you, Kamran. Air leaks are bronchopleural fistulas are ferocious. That's the best way. Clinically, you look at the bottle and you will know this is a bronchopleural fistula, not an alveolar. They are ferocious, really bubbling away to glory, and they don't settle at all. No matter what you do, they don't settle at all. And the whole idea of putting suction is that the suction sucks out more air than what is leaking. In a bronchopleural fistula, no matter what you do, it's a one continuous communication. The more suction you apply, the more the air leak happens. In the bronchopleural fistula, that's not true in an alveolar fistula. In an alveolar fistula, just the lung comes up and sticks to the chest wall. So it is quite ferocious, and you know it. You look at the bottle, and when you get it is the bronchopleural fistula. And the history is also important to understand. You have to take a proper history to understand what is happening. Post-surgical, after surgery, if you've done a lobectomy or something like that and you're getting ferocious air leak, it is your bronchus which has given way. 5,000. If it's a decortication, you can expect 3 to 4, 5,000 leak. That's okay. But if you've done a lobectomy and you're getting 3,000, 4,000 air leak, I will go in the same night because I know my bronchial stapler has given way. That's a different thing. That's a different scenario. Yes. Next.
Sir,
Yes, Vinita.
sir, I have two, three doubts. One is regarding the talc. You said talc is available in India, but our hospital pulmonologists always say maybe it is not available in our local area. So they use bleomycin. So other than talc or next to talc, which one do you prefer to use as a fluorodesis, medical fluorodesis?
Just for your information, I will give you remind me, Nikhil, can you just email her the number of the agent who is responsible for talc in India? It's available all over India. It's just
Yes,
that
I'll share it.
your pulmonology doesn't know. So these guys are the agents are the distributors for talc in India. And I know them very well. So it's available all over India. They will supply to your hospital. So that's not a problem. Now, if I don't have talc, what will I use? That's a real problem because, in the old days, we used to use tetracycline. Now, tetracycline is not available. In Taiwan, they have done extensive studies with minocycline, but even minocycline has gone off the market. You have an option of using bleomycin. I personally have never used bleomycin. I don't know how toxic it is to the patient. So better than that, I would use betadine. 1 or 2, I would use the patient's own blood to do blood fluoridation. Blood is a very good fluoridizing agent in the chest. But then you be very careful because blood is also a good culture medium. So if you put in stuff like that, you've got to be completely sterile. It should be done in theater so that you don't convert a simple air leak into an empyema. So you've got to be very careful. So better is better. Betadine works. To be honest, there is no evidence to say that. I would take him to theater and do whatever I need to do. I would do a corectomy and put it. But betadine is...
When you use a talc spray, the xylocaine is also included in the spray solution?
No, because these sprays are used in general anesthesia. So that's not a problem. Patient is in general anesthesia. When we spoke about the lignocaine and xylocaine, we are talking about bedside fluoridesis. Bedside fluoridesis, in fact, some people say that before you put in the slurry, you must put in lignocaine, into the pleural area and let it absorb. The only problem is the pleura is such a large area, and how much lignocaine can you put in? There is a restriction to the amount of lignocaine that you use. The dose is 7 milligrams per kilogram body weight. And it is not the strength that you have to use, it's the volume that you want. So anytime the anesthetist tells me that I can use a 7 milligram per kilogram body weight of 2%, 15 ml, then what I'll do is I'll take 15 ml of that plus 15 ml of saline and make it 1%. So I have 30 ml to put. You see, so it's the volume that is more important. And the other thing is, if you use lignocaine with adrenaline, you can increase the volume even further because the adrenaline causes local vasoconstriction, and so lignocaine can use more volume. So these are some tricks to increase the volume of lignocaine that we can do.
Sir, in the management of secondary spontaneous pneumothorax, like a patient with underlying emphysema, if it is affecting predominantly one side and with a bullous lesion of, suppose bullous lesion of left upper lobe predominantly, with a second episode of pneumothorax. So otherwise a fit patient for surgery, when we go in, is it mandatory that along with bullectomy we do a pleurectomy also?
So you said the pneumothorax is on the left side.
Yeah.
There's a bulla in the left apex. Is that correct?
Left upper lobe. There are multiple bullae on the left upper lobe.
I would
The lower lobe is relatively small.
Yeah, I would do a
So,
bullectomy and a pleurectomy. That's my treatment of choice. You could do a bullectomy and you could put in talc, or you could only do a talc pleurodesis, depending on how fit the guy is. But if he's a fit guy and he's a young guy, I would go in, do a bullectomy and a pleurectomy. That's my choice. But sometimes if it's got a lot of emphysematous changes in the lower lobe as well, I may use talc as well. So it all depends on what the patient has got. You have all these choices in front of you.
Pleurectomy is apical pleurectomy or?
No, my pleurectomy is not apical pleurectomy. I actually do a subtotal pleurectomy, which means from the apex all the way down to the diaphragm. And the only thing that's left behind is the one on the surface of the diaphragm and the mediastinal. I don't do mediastinal. So I go anteriorly up to the internal mammary artery. Posteriorly, I go up to the intercostal, the paravertebral gutter. So up to the sympathetic chain. And I personally don't do apical pleurectomies. I want a full pleurectomy to be done. And Kamran will vouch for it. I've always told you guys that you need a full pleurectomy. And the areas where I can't get the pleura off, I will do abrasion. So I take either a peanut, or I will use one of those scratch pads that you use to clean the diathermy. I will attach that to the tip of a Rampli sponge holding, and I'll push it in and try and do all those corners. So I do a subtotal pleurectomy. There is no such word called as a total pleurectomy, because we are not touching the diaphragm and we are not touching the mediastinum.
The point about Dr. Vinita's question about bleomycin. In the last 2 years, I've used a little bit of bleomycin, but the primary indication remains malignant pleural effusion and not pneumothorax. For pneumothorax, we tend to use either talc, or as I said, even povidone iodine if talc is not available. But for malignant pleural effusion, bleomycin works really well.
I see. I have personally had no experience with the bleomycin. I have never looked into it. I have always used tetracycline. But now talc is available. For me, it's freely available. So I don't know why you guys are struggling with it. We'll send you the, the same guy who does stents is the guy who does talc as well. I don't remember his agency name. Kamran, does it ring a bell? The guy, you know who I'm talking about?
Yeah, Kushal is the guy.
Kushal is the guy. And what's his agency called us? Anyway, it will come to us. We'll send it to you. Nikhil knows who we're talking about. It's freely available. It's not a problem at all. In fact, he comes to me every month or 2 months. He comes and says, "Sir, the talc is not selling. The talc is not selling." And I tell him it's not selling because people don't know about it, that it is available. Every meeting I go to, I get people who ask me, talc is not available in India. That is not correct. Talc is... Okay, next question.
Sir, what do we need to know about re-expansion pulmonary edema? When does it occur and what happens when it occurs? What we need to do?
Yeah.
Okay, so when re-expansion pulmonary edema, the clinical features that you will have when it develops after putting in a chest drain is that the patient will have a sudden bout of dry cough, which would not be responding to your nebulization. His saturation may drop for a while, and then you will have to increase the flow of oxygen. If you do a chest X-ray, you will find some opacities on the side where the lung has re-expanded, and sometimes also on the contralateral side. If you do a CT, you will find that there is ground glass haziness in the lung which is re-expanded. The scenario where re-expansion pulmonary edema usually develops is when, if we're talking about a pneumothorax, when the pneumothorax is of a fairly large size and has been there for a long duration. And if you suddenly decompress that pneumothorax, and also it's seen that if you suddenly decompress such a pneumothorax and connect it to a suction, there are chances that you may develop re-expansion pulmonary edema. Similarly, in case of a long-standing effusion and a massive effusion, when you drain it all of a sudden, there are chances that you can develop pre-expansion pulmonary edema. But the good thing with the pleural effusion as compared to a pneumothorax is that you have a control of the amount of fluid being drained when you put in a chest drain. However, when you're draining air, you don't have, you really don't have a control of how much air you can drain in a particular amount of time. Anyway, if your diagnosis of re-expansion pulmonary edema is confirmed, most of the times these patients are managed conservatively. You put them on some form of non-invasive ventilation like a BiPAP. You can give them diuretics, and it's just and most of the patients would come out really well with these two modalities. Sir, would you like to add something?
Yeah, a couple of points I want to add. Number one is it starts with a dry cough, but it is always ends up with a frothy cough.
Sure.
It becomes very frothy, and the expectoration is pinkish or blood stained. Okay, that's what happens. They really become bubbly and chesty, and it comes out. Commonly not seen with pneumothorax, but seen more with large pleural effusion, which you drain under local anesthesia with a chest drain. So in that scenario, you must do a controlled drainage, which means let out 500 ml, put a clamp, wait for a little while. So most people will let out a liter, then clamp for an hour or so, and then let out another liter and clamp for an hour or so. So that's how people drain large. But to be honest, the same situation we do on table when we are doing, drainage of pleural effusions. And on table, I have never come across a pulmonary re-expansion edema. So the pulmonologists are quite scared about it. I think there's something in the physiology which changes once they go under anesthesia. And so the drainage is more controlled. And also you are on a single lung ventilation. So because you're on a single lung ventilation, the VQ perfusion changes. The VQ perfusion pattern changes. And that is why probably the incidence of re-expansion edema is less when we do it under general anesthesia. As opposed to that, when you do it under in the ward after putting in a chest drain and let the fluid out, suddenly it's just very simple to understand. Suddenly a huge amount of the lung re-expands and a huge amount of blood flows into an previously collapsed lung. And because that flows, the VQ perfusion changes. You see, the ratio of the perfusion changes, and that affects the pulmonary pressure changes because of the sudden flow of blood into the collapsed lung. And as a result of that, the capillary permeability gets damaged. And because the capillary permeability gets damaged, the fluid escapes from an intervascular space to an extravascular space in the lung. So this is the simplest way to understand it. A collapsed lung having no blood flow because of the large fluid pushing it, suddenly you take the fluid away, the lung re-expands because air blows it up like a balloon. And then suddenly the blood rushes into that area. And because it rushes, the VQ perfusion ratio changes and the hydrostatic pressure changes, and that damages the capillary permeability. This is just a simple explanation. May not be very scientific, may not be very physiological, but a simple way to understand. So that is why you must do a controlled thing. So there is time for the pressure to reach an equilibrium. You understand? That's why you do a controlled release, so that there is adequate time for the pressure to reach an equilibrium. And so there will not be capillary damage. That is the philosophy. It's spoken of. I have seen just one or two in my career. I haven't seen this but pulmonologists are very scared and they talk about it all the time. And in the exam, I think you should talk about it. In the exam, you have to seem to be safe. So you shouldn't say that it never happens. You should say, yeah, it is a risk. If it's 2 liters of effusion, I will not drain it straight away. I will put in a clamp and slowly drain fluid little by little. Whether you wait 10 minutes, 20 minutes, 1 hour, it doesn't matter. But really, these guys are short of breath for many days. You can drain it slowly. There's no need to rush. Yeah? Okay. Next
Sir,
question.
sir, Amol here, sir.
Yeah, Amol.
Sir, it is regarding talk.
Hang fire
Yes, sir.
1 second. Okay, just 1 second. My battery is gone low because we've been talking for so long. Let me put it on charger. Just one
Yes, sir.
second. Keep talking, keep talking.
Yes, sir. Sir, what is the body reaction to talk? Are there any granuloma formation and stuff like that? And how to manage if it happens?
Yeah, Kamran.
Talc has its own share of, I mean, even sterilized graded talc has its own share of risks and side effects. See, when you're instilling any foreign body into the pleura, there is always a risk of anaphylaxis. You have to be prepared with hydrocortisone and antihistaminics, as previously mentioned. There's some, although with talc, the complaint of pain, chest pain is not that great as compared to tetracycline and other pyridizing agents. But still, there can be some amount of chest pain after you put in talc. They can be itching, they can be rash over the body, they can be bronchospasm and desaturation after you put in talc, but the percentage is not that great. However, the question you said about granuloma formation, if you're using a graded talc, as we discussed during the lecture, when the particle size is 5 to 70 microns or greater than 5 microns, you will probably not get any granulation formation.
One thing you forgot is arrest.
Arrest, absolutely. Yes, arrest. Yeah, you always have to mention in the consent.
I think you put in the talc and he arrested. Do you remember that case?
Yes, yes. We had to rush the patient to ICU.
Rush the patient to ICU, and we eventually lost the patient.
Yeah.
These patients can have cardiac. It's important to know that.
Thank you, sir. Thank you.
Yeah. Next, who else wants to ask a question? So I think this was a fantastic discussion. I'm just going to stop.